Hello, everyone. Thank you so much for being here. Thank you so much for joining us today on Monday evening. I'll give maybe about a minute or two just to let everyone get into the room here. Thank you so much for being here. Thanks for waiting. Give a couple more seconds. All right. Well, in the interest of time, I'm going to go ahead and get started. So, thank you everyone for joining us tonight for Living with Tourette and OCD, a community perspective. My name is Dao Duong, and I go by she, her pronouns, and I am the program lead for professional and community education here at the Tourette Association of America. I'm also joined by my colleague Alexandra Walsh, manager of programs, who will be helping me out in the chat and Q&A later tonight. So a bit of a disclaimer, tonight's event is being provided as part of the Tourette Health and Education Program in partnership with the CDC. So the views expressed by tonight's speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the US government. And so we are very excited to present tonight's roundtable discussion in partnership with the International OCD Foundation, actually, which is the largest nonprofit organization dedicated to serving a broad community of individuals with obsessive-compulsive disorder, OCD, and related disorders, their family members, loved ones, mental health professionals, and researchers around the world. So we're lucky. We're in for a treat tonight. We will be hearing from individuals who have TS and OCD, hear from both the clinical and the educator perspectives on supporting individuals with TS and OCD. I want to quickly remind everyone that after the roundtable portion of tonight, we will be asking attendees to partake in a brief survey to let us know what you thought of tonight's program. Tonight's session, it's made possible by support from the CDC. So not only is your feedback important to us at the TAA as we consider future programming, but it also demonstrates to the CDC the value of programming like tonight. So please share your feedback with us. Please, we would love to hear from you, and we take your feedback very seriously. So I appreciate that in advance. So with that said, I'm going to go ahead and introduce our wonderful speakers for tonight. So first we have Sam Reall. Hi, Sam. Sam was diagnosed with TS, OCD, and anxiety when he was 6 years old. These are all conditions that have given him challenges throughout his life, but he has been blessed with many people to help him through challenging times. He now wishes the same for others. Sam is actually 21 years old and currently attends Brigham Young University in Provo, Utah. Sam was also part of the TAA's Rising Leader program. Next, we have Ivette. Hi, Ivette. Ivette Aguiar is a 26-year-old healthcare worker diagnosed with TS and OCD, specifically working as a speech-language pathology clinical fellow since graduating with a master's degree in May of 2023. She's currently completing her clinical fellowship, working with and advocating for children with a variety of exceptionalities, using her experience with TS to help navigate sensitive topics. Yvette has been a part of the TAA Rising Leader program, similar to Sam, since it was first established. She looks forward to continuing to make an impact advocating for individuals with TS through her work in the healthcare sector. Yvette has also recently become CBIT certified and hopes to implement that into her practice in the future. Next, we have Dr. Shannon Bennett. Dr. Bennett is an assistant professor of psychology and clinical psychiatry at Weill Cornell Medical College and an attending psychologist at New York Presbyterian Hospital. She is a licensed clinical psychologist with expertise in cognitive behavioral intervention for children, adolescents, and adults suffering from OCD, anxiety disorders, tic disorders, and other related conditions. Dr. Bennett is the clinical director of the NYP Youth Anxiety Center and the director of the Weill Cornell Tourette Syndrome Center of Excellence. She provides diagnostic assessments, cognitive behavioral therapy, CBIT, and consultations in her clinical practice, and is involved in clinical research studies to improve the understanding of treatment of tic disorders and anxiety disorders. Dr. Bennett received her BA from the University of Notre Dame and her PhD from Boston University. Next, we have Dr. Elle Brennan. Dr. Brennan is a pediatric clinical psychologist within the Division of Psychology in the Department of Psychiatry and Psychology at Akron's Children's Hospital. She received her BA in psychology from Case Western Reserve University in 2010 and both an MA and PhD in clinical child psychology from Kent State University. Dr. Brennan also completed a full-time internship in clinical child pediatric psychology at the Alexian Brothers Behavioral Health Hospital in 2019 and a 2-year postdoctoral fellowship in child, adolescent, and pediatric psychology at the Mayo Clinic in 2021. She started her professional journey in Akron's Children in 2021, where she provides clinical care to families, training for master's and doctoral students, and serves as director for the OCD and Anxiety Treatment Service. And last but not least, we have Ez Homonoff. Hello, Ez. Ez currently works as a certified school psychologist in the public schools of New Haven, Connecticut. Prior to this, Ez worked as an academic coach, disability support services assistant, and early literacy interventionalist, working with elementary through college-age students throughout their many years of experience. Outside of working with their students, Ez has been a proud proponent of mental health awareness and an IOCDF advocate for many years. A passion jump-started after being diagnosed with OCD at 12 years old. Their goal, both in career and their advocacy, is to make others feel heard, understood, and valued. So thank you to you all for being here tonight. I'm going to go ahead and start off first with actually Dr. Shannon Bennett with the first question of tonight. So can you explain to the audience, Dr. Bennett, how OCD may be diagnosed with TS? And if so, what's the difference between OCD and Tourette OCD, which we often hear a lot?
Sure. And this is such an important topic. I'll try not to go on for too long, but the first step for making any diagnosis is to schedule a thorough intake assessment. And we can talk more about kind of the steps leading up to that process. But to share with the doctor, psychologist, psychiatrist, or other medical or mental health professional that you're meeting with the symptoms that you're experiencing. And we know that OCD and Tourette syndrome commonly co-occur, which is why we're talking about this topic today. It's so important. When I'm thinking about what we call a differential diagnosis, so we want to decide if someone is experiencing symptoms of OCD, symptoms of Tourette syndrome, or perhaps symptoms of both OCD and Tourette syndrome, questions that I'll often ask is learning more about what are the behaviors, the symptoms, the experiences, sensations, and thoughts that the individual is experiencing. So we know obsessive-compulsive disorder, obsessions are thoughts, images, impulses, sometimes a feeling that one experiences, and compulsions are behaviors or routines, habits, things that someone does in response to the distress, anxiety, or other uncomfortable feelings that are associated with those thoughts. Whereas with Tourette syndrome, often someone experiences an uncomfortable urge, sensation, or feeling prior to the experience of a tic, but there's not typically a thought associated with it. So that question can be one that is helpful for a differential. I may ask someone right before you have this behavior or this tic, this experience, is there a thought or a worry that comes to mind, or is it more of a feeling? And that can be a helpful question to tell the difference for some people. Now, we also know for many youth and for some adults as well, even OCD, an OCD compulsion can be associated with a feeling, like something just doesn't feel right. And then it can be a little tricky to really try to tease apart what might be a compulsion versus a tic. And we can start to think about what other symptoms the person is experiencing. If there are other sort of typical OCD symptoms, perhaps that one symptom falls in the OCD bucket. If there's other tics, perhaps it falls into the tic bucket, or there may be both present, which is also common. And from a behavioral treatment perspective, we might treat that the same way, regardless of whether it's a compulsion or a tic, but it is important for our own information, for one's own information about themselves, as well as for medication to understand the difference between OCD and Tourette. And Tourettic OCD is that kind of combination in the middle where someone is experiencing more of this just right phenomenon, where there's somewhat of a gray area between a compulsion and a tic, or there may be kind of a little bit of both.
Thank you so much, Dr. Bennett. That was a really great overview. So I want to ask Sam, so what OCD symptoms have been the most challenging for you?
I think for me, it's definitely dependent on what stage of life that I've been in. But for me, probably the most challenging symptoms I've had started a lot when I was a freshman in high school, around maybe like 14 years old. I started developing some pretty extreme obsessions with just the way my body looked and basketball and a couple of different things. And it kind of got to the point where some of my compulsions to offset it got pretty extreme, where I have to kind of weigh myself multiple times every single day. I kept track on my Google Sheet spreadsheet of how many minutes a day I was sitting compared to standing up, compared to like walking around, to doing like light, medium, or heavy exercise to try to like perfectly guess how many calories I was burning. I'd have like one meal a day of around like 600 calories while I'll be working out like for like 4 hours every single day.
Mm,
Um, got to the point where I was pretty bulimic and just a lot of other symptoms that were really tough because of my obsession with kind of the way I felt my body looked, and then a lot of other extreme things with basketball as well, because I've always liked basketball a lot, and I became really obsessed with how good I was at basketball, wanted to go to college for that and different things like that. And then it also led to a lot of different sporadic OCDs, different compulsions and rituals that would make it take a really long time in the morning for me to get ready for school. Sometimes it would take me like 2 hours in the bathroom just because I was like having to do a lot of different rituals that made it take a really, really long time. Luckily, I've been able to get a lot of help where a lot of those symptoms aren't nearly as severe as they are before. I would say now, some of my more challenging symptoms is a lot of the sporadic OCD still, where I get very obsessed about things being a certain way, and when it's not the way that I want it to go, it can be pretty hard for me, and that leads to sometimes a lot of like rituals and compulsions that I have to kind of walk myself through to stop me doing it. So I spend like a few hours a day just doing stuff that I aren't productive because of my rituals.
yeah. Thanks for sharing so much, Sam. Yvette, kind of similarly, what OCD symptoms impact you the most?
Yeah, I mean, it's a good question. First of all, I've experienced some what Sam has expressed as well, especially with like those persistent thoughts and worries and like perfectionism, like the obsessions. Um, the perfectionism prevailed a lot, like when I was very young. So like elementary school up to college, graduate school, just having that feeling of like needing to get straight A's, like be good at everything, so much of a people pleaser to the point where it was really damaging for me. It kind of it made me feel bad in my self-worth because I based it on my achievements versus myself as a human being. And I've been learning to kind of like grow out of that and improve that through therapy and things like that. Um, but other things I've had was like something going wrong. Like I will think something is wrong without a real reason in reality. So like I'll just get this sudden thought or like impulse that something bad is gonna happen. And there's other ones that are more typical. People think of like OCD, like, oh, you have to touch something or the sanitize or whatever. I had more of those when I was younger, but one that still persists is like if something intrigues me, it's like I have to touch it. So like if it's intriguing, it's also irritating. Like I don't know how to explain it. It's like when someone scratches on like a chalkboard. It's like it's very uncomfortable. So like my husband has like this like kind of pointed nose and I always want to kind of flip it up. Like I want to make it like rounder, which is impossible. And I'm like, can you get a nose job? Like I don't want to do this anymore. But which is funny, but it can be irritating at times because it's like, oh my gosh, can I just not like can I just take a break? Like can my brain just turn off a little bit? But I know we'll get into that later, like steps to kind of help relieve that.
Oh, no, thanks for sharing that and about your husband's nose tonight's discussion. I want to turn it over to Dr. Brennan and ask, can you explain to the audience how OCD symptoms can change over time as someone ages, they transition to adulthood, etc.?
Yeah, OCD is, I like to think of it as one of the most creative mental health conditions because if your brain can think it, OCD can turn it into an obsession or a compulsion. Um, and so what's kind of neat, a lot of disorders have like a really predictable almost aging trajectory. Like, oh, when you're little, it's going to look like this. When you're a teen, it's going to look like this. When you're adult, it's going to look like that. OCD says, no, I'm going to do me. You can be four and have the most elaborate, mature seeming worries, and maybe you need to tuck your teddy into bed to make sure that those worries don't come true. Or you can be 40 and have a really, basic worry and have to do some elaborate compulsion. It doesn't, from my experience at least, it doesn't necessarily have that same sort of age trajectory. That being said, I think experience and what you're aware of in the world can certainly influence what your obsessions might look like. So a kid who doesn't have as many experiences might not have as broad a range of worries, or one can only hope not as like devastating, scary worries. But again, OCD finds a way a lot of the time. Um, and then there is certainly something to kind of brain maturation and, learning through experience. And so sometimes adults might, and not always, might have a little bit better control or a better way, like better ability to kind of reality check their worries.
Mhm.
So they might not express or report kind of the broad range of creative things that OCD can come up with. But it's honestly been my experience that that's just not a cover, but like they're kind of working on the stuff, but they're still having these really elaborate kind of internal experiences. Um, So yeah, I wish I could say, hey, there's this beautiful trajectory that we can predict and tackle in this way at each age, but it's so individual because it's all about that creative brain being awesome and OCD coming in and being a little pest.
Yeah, that's great. Thank you so much for sharing that, Dr. Brennan. Let me turn to Ez now. So I wanted to ask you, in your role as a school psychologist, like what are some of the biggest challenges at school for students with OCD and, and TS as well?
Yeah, I think that one of the things that I see impacting students most is actually just kind of anxiety in general and avoidance of things. So one kind of key way would be like students who might avoid work or might avoid school altogether. And it's because they're afraid of something either within the school, or it's just so overwhelming to be in school and have all of these anxieties and obsessions and compulsions. And the way that that can kind of manifest is often students say, I don't want to go to school. And sometimes the parents are like, they don't know what to do. So they say, okay. But then it kind of reinforces that, oh, I can stay home from school. And it's not in a sense that they want to skip school, but they're so anxious that they'd rather miss school than be in the school building. And then similarly with work avoidance, work and schoolwork can often create or sort of reinforce other common OCD compulsions. Like I see students that reread or rewrite. So like they may feel like they need to read a paragraph over and over again, or something bad will happen, or they might just feel like they need to read it until it's just right is another common feeling, or rewriting where I've seen also retyping. I myself had a lot of those issues when I was growing up, and it slows you down significantly with work. And it can also even lead to just not wanting to do the work because you're just so afraid of starting. And then perfectionism is the last way that I see it impacting students the most would be because a lot of times people with OCD have that perfectionism based habit, or they feel like things need to look a certain way or be just right. And that can sort of make work. Some students actually finish the assignments and won't even turn them in just because they don't feel like it's done or it's not quite right. I've seen that a lot. And this often leads to then teachers thinking that the child is slacking off, or the child is being lazy, or the child is too focused on things being perfect and that they're not focusing on the bigger picture, which to an extent is true, but it's mainly a manifestation of their disability. And part of my work in the past has been working with teachers to kind of help them see, it's not that the student isn't trying or that they're not motivated to do better. If anything, they're so motivated to do better that it's causing additional anxiety and then even more avoidance. And it is harder, I think, for teachers to sometimes see that because they just see, oh, the student is not turning in their assignments or not coming to class.
No, that's really, wow, that's insightful. Thanks so much, Ez. I think you highlight the importance of the education awareness, right? Especially in a school setting. So I kind of maybe want to switch gears and talk a little about like the impact of OCD. So Ivette, I'll turn to you. So, as a speech language pathology fellow, how has OCD impacted your professional life? Like what have you done to be successful at work?
Yeah, so thank you for asking. I've worked in multiple settings due to like being in my graduate, like clinical externships. And then as a clinical fellow, I worked in the school system last year. And it was very difficult sometimes because being with a group of kids and, you know, having TS and having OCD, it takes a lot of pressure of being like on and being in a distracting environment. Sometimes I need like a sensory break or a break for my brain to just like reset. So, you know, some strategies I've used is just organizing my tasks. So like even using like the Pomodoro method, I think that's how you say it, right? Like the little timer, kind of doing small snippets of a task instead of having the overlooming task, because like I also as a perfectionist will, like as was saying, not do something because I'm scared I'll fail. So if I put it in little tasks, it's easier. And kind of like deep breathe, like I like meditation. So deep breathe 3 to 5 breaths, like when a student isn't in the room in like my 5 minute break. Um, and just try to let thoughts come and go as well, and not put too much pressure on yourself. If you need a break, even if it is a break from work for like a medical reason such as mental health, I mean that's just as valid as any other reason. So I think those are impacts that can have on work, not just like compensating, but knowing when you need a break.
No, that's very important, knowing when you need a break. So, Sam, let me turn to you. So, how has OCD impacted college life for you, right? You're at university. So, what do you do to be successful in school?
That's a good question. In terms of how it like impacts me, I think one of the biggest ways is it takes me a really, really, really long time to get something done sometimes. Sometimes reading can be difficult for me, I think like was mentioned earlier, because sometimes I have to like read something a certain amount of time, or I have to kind of like after every 5 words, I have to kind of pause and like sit in silence and read the next 5 words, and it just makes it take a really long time. Or when I'm in class, it's really hard for me to always stay focused because I have a lot of obsessions that sometimes try to make their way into my thoughts where I'm trying to focus on class, and suddenly I have this random thought about some OCD obsession that I have, and then I realize that's been like 10, 15 minutes where my mind has just been going over this fear and what I'm going to try to do to offset the fear. And I didn't listen to anything that was said in class, so I have to kind of go back and do a lot of things like independently by studying like by myself or the textbook. Um, so I feel a lot of things just take a lot longer for me. Something that I've tried to do to be more successful is making sure that I would get enough sleep, because I've noticed when I do that, my tics and OCD proportions aren't as bad when I get enough sleep. And I've learned to have to be really, really good at setting goals and making plans, because otherwise I can get super focused on just one aspect of my life, whether it's my social life or it's school or sports or something different, and forget about the other aspects of my life. So when I set goals and try to keep myself accountable, it helps me make sure I'm not just obsessing over one little thing, but focusing on all aspects of my life that I need to kind of prioritize. So that's definitely been a huge help for me.
No, that's great. The goal setting, and I hear the prioritization has been really helpful. Thanks for sharing, Sam. Dr. Brennan, I think, I want to ask you about, the what kind of treatments or therapies are available, right, for OCD, and how may those treatments differ for like Tourette OCD, right? Because we all kind of understand that Tourette OCD, it's like a blend, right, of both OCD and TS symptoms. So can you elaborate more a little bit on the different treatments?
Absolutely. Yeah, I like that you said a blend. I literally drew a little Venn diagram on my little paper in front of me just for that visual of you have OCD, you can have Tourette's, and you can have a true blend, which can be a little bit of both that are kind of separate, or it can be a true intertwining of that OCD kind of just rightness with tics, or with a Tourette kind of profile or a tic profile. Or it can even be more than that, right? It can be I have some Tourette OCD, I have some regular OCD, and I have some regular tics, right? So exciting. Our brains are amazing. They can do a lot. They just don't always put the energy where we want it. But in terms of treatment, the gold standard for OCD and anxiety disorders is exposure therapy. Classic is exposure with response prevention. We're going to do something, we're doing exposure that's going to help us face our fear, face the thing that's uncomfortable, face the thing that's causing us distress, and then learn to tolerate that distress. Traditionally, that's looked like kind of a habituation model, which is if I were afraid of dogs, I might kind of gradually start approaching dogs do something to calm my body while I'm approaching dogs, so that I'm kind of letting my body experience a calm, relaxing, physiological experience while my brain's going. But there's also evidence for more of a, let's ride that anxiety wave or ride that distress and almost like urge surf our way, notice the discomfort and kind of own that discomfort, which I see as kind of a very like Tourette profile, right? Like, let me just dive in and own this. My brain wants it. Let's go. On the Tourette side or the tic side, right, is CBIT or habit reversal training components. And so just like there's that Venn diagram overlap of OCD and tics, you can kind of blend the two together to treat some Tourettic OCD with components of each maybe separate for the symptoms that kind of stand apart. But I like to think of it, both OCD and tic disorders have kind of a compulsivity, impulsivity piece to them. And so being able to recognize, what am I compelled to do? What is that compulsion? Is it to fix something? Is it to tap something? Is it to do a tic just because it feels better when I do it? And then what's my impulse, right? How much control do I have over this? In OCD, theoretically, you have a little bit more control over the impulse. In a tic, it's pretty automatic, but that's not always black and white true. So I like to think of this kind of commingling of these treatments as, how can we parse out, how do we face the discomfort? How do we mess up that tic or mess up that just right urge or do something just wrong is kind of the classic wording. And there are so many ways to do something just wrong. It's not a perfectionistic thing. You can mess things up in all kinds of ways. But how can we do that and kind of ride that urge, ride that feeling of wanting to fix it, and then allow that urge to pass, which is really that habit reversal component, right? In habit reversal or in CBIT, we're going to notice what our tic wants us to do. Maybe it wants our neck to go to the side, and we're going to practice holding our head nice and firm and strong and upright until that urge goes away. So when you have kind of that just right urge of, maybe I need to do this a certain number of times before it feels just right, we can either practice that competing response of holding our neck just right so that we don't complete the tic, or we can mess it up. We can say, oh, you want me to go 5 times? I'm going to go 3 or 17, although don't do 17 with a neck tic because that will not feel good. Or we can do something completely different to like tackle that just rightness. So it's kind of a fun, and I like OCD because it's creative. It's a really fun kind of creative treatment if we can figure out how to take that OCD or that tic or that Tourettic OCD, there we go, bully. Can you tell that I work with kids? And just give it what it doesn't want. So it's really about like messing up those compulsions and those impulses.
Oh, that's great. Now, Dr. Bennett, so anything to add to that? You've heard a lot about the different types of impact, right, of OCD on an individual's daily life. Anything else you'd like to add to that piece?
I don't have too much to add. I think everyone really covered a lot with this question. I was just thinking about piggybacking on what Dr. Brennan said about how OCD can really kind of run with whatever your brain can come up with. And unfortunately, the same can be true for how it can interfere in one's life. So ways that it can take up your time, ways that it can cause you to feel really uncomfortable or uncertain, even in the treatment of it. And I agree with everything Dr. Brennan said about how we can combine both CBIT for tics and exposure and response prevention for OCD. And the common theme there is riding the wave of discomfort long enough to choose a behavior that's in line with your goals and where you want to go. And doing that because it's important to you in your life and not letting the OCD take control. And so that can happen in school, that can happen in work, that can happen with friends, in our family life. And it's really hard work, this type of treatment, behavioral therapy. There are also medications that can be helpful for both conditions. But even with medications, the behavioral therapy is so important, right? We think about, a colleague that I work with gave me this analogy once, and it's kind of a funny one, but if you think about the analogy of using steroids and exercising, right? And not that we're a proponent of using steroids and exercising, but if someone were to use a steroid and not exercise, you wouldn't see the same kind of benefit in building muscle. And someone can exercise and build muscle and work really hard and experience that discomfort, but also that payoff. And then if they combine the two, they may have a little bit of an advantage in how much their body responds to the workout that they're doing because of the steroids. Now, there's a lot of other really unpleasant side effects and problems with certain steroids, but we know that some medications for OCD, in combination with that exposure type of work, can give you that little extra edge. It decreases your anxiety enough to be able to ride the wave of that discomfort. It's easier to ride that wave if it's a 4 out of 10 than if it's an 8 or 9 out of 10. So for some people with moderate to severe OCD, the combination may kind of give you a little more advantage when you're doing behavioral treatment and make that process slightly more easy. It's never totally easy, but it can be more helpful.
Thank you. Thank you, Dr. Bennett. So I'm going to just kind of, in the interest of time, maybe move on to talking about maybe personal strategies and accommodations, actually. So, Sam, I'd like to ask you, are there ways that your OCD has been an advantage for you?
Not really. I think especially after I've gone to, years of therapy and learned how to navigate my symptoms more, like healthier ways. I'm somebody who typically when there's something that I really care about, I stress over it a lot, and I do tend to be more successful than I probably would be if I didn't have OCD in different areas of my life. Some things that I care a lot about is like my relationship with my family, my relationship with God, or trying to help other people who also have stress and OCD anxiety or other things like that. So I have found that it's led me to be more successful in those types of things because I'm able to hyper focus on something for a super long period of time and put an amount of effort on the things that I care about. I think another way it's helped me is, am I a little muffled still?
I think you're coming off a little muffled. I think maybe it's just not me.
Is it better now? I just took my earbuds out.
Yes,
Okay,
much better.
perfect.
Thanks, yeah.
Um, so and I'd say the other way that it's been an advantage to me is just having greater empathy for other people. Just like anybody who goes through any challenge, oftentimes when you can, go through something hard in your life, you have a greater empathy and desire to help other people who go through similar things. So I think it's also helped me have a greater desire to want to help other people out and understand a little bit more about what they might be dealing with.
Oh, thank you for your empathy, Sam. Your desire to help others. So similarly, Yvette, what are some of your OCD superpowers? What's your go-to?
I actually looked this up before, like just common ones people may think of. So like organizational skills, creativity, empathy, which are all true. I think personally for me, it's the fact that it's given me the opportunity to explore shame and vulnerability. I read this book from Brene Brown called Daring Greatly, and it really helped me realize how much shame I felt about some of these symptoms and kind of be able to stop masking in front of people slowly in the process, and accept that this is who I am and be able to be vulnerable to other people. Because like, to be honest, today was not my best day. Like this past week was not my best week. We just moved to Miami, so it's been very stressful. But being vulnerable enough to say that like on this recorded, now I'm scared it's on recorded webinar, and know it's okay to have those like ups and downs. I think that's been my biggest superpower or biggest thing that I've gained from having this, the biggest strength, I guess.
Thanks for sharing, Yvette. Dr. Brennan, so, for parents and or families, right, how can they support their children to utilize those like learned strategies, right, at therapy at home? How would they support that?
Yeah, I think the first most important thing is to validate your child's experience. Kids with anxiety, kids with OCD, kids with, and even adults, if you're supporting your adult compatriot, like folks with tics, they can be a little bit obnoxious, right? They can take a little extra work and they are struggling and need support. So validating their experience, being there for them, not getting angry when they have more tics or when they do their compulsion over and over, and finding just a place of acceptance in the house or in the home. Like that's so important. Beyond that, if you are seeking treatment, if you are in treatment, finding a great motivation plan can be so powerful, right? It doesn't feel good to do exposure initially. It doesn't feel good to deny your tics initially. It's really so helpful to have a sticker chart or, a piggy bank or getting to have a special privilege, something that's motivating that person to do the hard work. Being mindful about how you're accommodating in the home is also important. We, of course, want to accommodate certain things if someone really does need that extra support. But if we can pull back on accommodations over time, whether this is school or in the home, right? Helping that person kind of grow and find their skills and be able to practice those skills rather than say like removing the thing that's making them anxious or uncomfortable. We want to be able to do that. The other last thing I'll say is we know that these disorders run in families. So own your own experience. And if your kid's needing or wanting treatment for their tics or their OCD or their Tourettic OCD, and you have some of those same symptoms, dive in with them. Practice your skills together. Make it kind of a family affair, because that's really going to help that person feel heard and seen and make them want to engage in that treatment so that they can feel better. And then the whole family unit can feel better.
Thank you so much for sharing that, Dr. Brennan. Dr. Bennett, so kind of on the provider side of things, how can clinicians help families better understand, their child's OCD diagnosis, especially when, individuals with TS and OCD also often have other co-occurring conditions? What are the roles that providers can play here?
I mentioned in the beginning how important those comprehensive initial assessments are, and I find for many people, the assessment in and of itself can be therapeutic. Just to know that someone, and there are validated, gold standard, well-researched tools that we often use when we're making a diagnosis. So we'll run through a list of different types of tics or different types of OCD symptoms, and many people will feel like a light bulb just went on, like, wow, I didn't know that was also a part of my OCD. And because that's on your form that's been used by thousands of people before, they feel less alone. So that helps to validate their experience. It's important for families to be able to ask questions, to understand, what OCD is, what their child's experience or family member's experience is, what the experience of tics is like for people. And then to know what treatment options have the most research supporting their efficacy and what combination of treatments or choice of treatments would work best for your child, your family member, or for your family as a whole. And particularly for parents and partners, that sometimes may also involve you, because people with OCD and sometimes individuals with tics may involve other people in their life as part of their compulsion. Or if they feel anxious about something like germs, for example, in OCD, they may want other people in their environment to act in a particular way in response to something that they fear might be germy. And so, number one, we talked about validating one's experience, understanding how anxiety can move us to act in ways that we may not want to, and can also hide behind other emotions. So for young children, they may tantrum, people may act out. We talk about the fight or flight system. That's the system in our body that protects us when we fear we might be in danger. So that can look like someone is becoming aggressive or angry, or it may look like they're frozen and withdrawing. And we have to understand where if anxiety, OCD is the motivation behind those behaviors, that can be really helpful for parents to understand. And then often in treatment, we may include parents or family members in the exposure process, which can feel really hard for everyone if it creates more distress temporarily for the person who is experiencing OCD and anxiety. For you to not participate in the ritual the way that they wish you would to calm down the OCD, that can be hard, but to understand that in the end, that will actually help the person. So there's a shared understanding with the therapist who's driving the treatment that while this is an uncomfortable process, it will ultimately lead to making everyone feel better in the end, and hopefully making life, a little bit easier.
Thank you. Thank you, Dr. Bennett. That was really great. Over to our school psychologist now, Ed. So wanting to see if you can share with the audience, how can educators, educational professionals, right, support students in helping them process like OCD and TS, and this other kinds of supports that educators can provide?
Yeah, I think there's kind of a couple different avenues that are important here. I would say one of them is kind of knowing your place. So I think it's really tempting for some teachers, or just educators in general, to feel like we need to help treat the OCD, but reminding ourselves that we're not therapists. And there's a reason for that. We're not supposed to be doing exposure therapy with them, but also we're not equipped to be treating the OCD in school. And I say that because I think there's sometimes is a common misconception that you need to either be helping the student get better, and so you can't provide any reassurance whatsoever, or you can't be aiding in compulsions. And that's true to an extent, but our job first and foremost is to keep our students functioning in school. And if that means accommodating OCD to an extent, I think that's actually kind of important. And what I mean by that is sometimes there are accommodations that students can receive with OCD through like a Section 504 plan or an individualized education program through special education. And it depends on the level of need for the student. Some students may not even need a formal accommodation plan, but there is sometimes some discussion over whether we're accommodating the OCD or the person. So for example, if a student is taking too long on their homework because they're being too wrapped up in the details and high perfectionism is keeping them from turning in assignments, giving accommodations to extend that. Sometimes I've seen pushback where, we're accommodating the OCD, but, if that's going to help the student turn in their assignment, it's not really our job or our place to say what's too much accommodation. At a certain point, we have to leave it up to the therapist, and we just need to help the student get through that school year. And doing what we can in that regard. I think also knowing to validate the student's feelings, but not the OCD. So what I mean by that is I've had a student in the past where he was very worried that he was turning into a monster, and he would often come up to the teacher during class and say, "Am I a monster? Am I a monster?" And she was going down the avenue of, I don't want to reassure this. So she would just say, "Stop it, go back, sit down." And I think that also didn't help either, because unfortunately that kind of doesn't quell the OCD when we tell the student to just stop it. I've also seen, when the student's erasing a lot, teachers saying, "Oh, just stop it, just you don't need to do that." Like, yes, I think the student knows that, but it's easier to sometimes say it than to actually, or to know it than to actually get themselves to stop. And so what can help is kind of validating and saying, like, I know that this is really tough right now. And just, being a listening ear, but then also making sure that you're not sort of reassuring the OCD too much, because I think if the teacher were to say every single time that that student had said, "Am I a monster?" and then if you reassure that student over and over again, the reassurance actually continues to build, and the need for reassurance continues to build. So it's almost like the student builds up a tolerance to the reassurance and needs more and more of it. So there's kind of a balancing act to that. What I've used in the past with students is actually like a distraction technique. So that way I'm not reassuring them, but with some students, they're more easily redirected than others. But like when that student would come up to me and say, "Am I a monster?" I would say, "I don't know. Hey, have you seen the new Marvel movie, blah, blah, blah." Because it was a student that really liked Marvel. So getting to know them on a level outside of their OCD, while also trying your best not to reassure is usually, I think, helpful, regardless of the age of the student.
That's really great. Thanks, as I'm hearing validating the feelings and not necessarily the OCD. So really awesome. Thank you for sharing that. I'm going to go ahead and move on to, I think, our kind of a section on self-advocacy. So I kind of want to hear maybe from Sam, actually, if you could explain, just one thing about your TS and OCD to your professors, colleagues, friends, what would that be?
I think like for me, somebody growing up who always had pretty heavy social anxiety, my biggest fears would always be just me ticking and people staring at me and just feeling super uncomfortable with that. And I it'd be really helpful if with all of, my friends, professors, colleagues, anybody, if I could just, explain to them simply about what Tourette syndrome is and some of my OCD compulsions, and just help them understand to not like stare at me when I do that, because that's led me to really want to suppress my tics in unhealthier ways in the past. I've learned how to be better at it, but it would make my life a whole lot easier because I'm always just so self-conscious of people staring at me for my tics or some OCD compulsions that I do. So I think just helping people to understand what it is, because a lot of it's just that they don't know, so I can't blame them, but helping them understand what Tourette syndrome is, what it may look like, and just how to react when they see me tick, which is just not reacting at all. I think that'd be what I would want to share.
Thank you. Thanks, Sam. Yvette, so what about you? Do you find that you often need to disclose to others, friends, work about your OCD diagnosis?
Yeah, so well, to friends, they know. All my close friends know, and my family knows, but in work situations, I usually always disclose, more so for legal protection, because when you disclose, you have the rights to get, legal rights and like ADA accommodations, things like that. And unfortunately, if you start to struggle because of certain disabilities you may have and you did not disclose and you do get penalized or fired, then there's no legal, there's not a precedent for you to be protected because you did not disclose before you started struggling. So I've learned, for me at least, that it's best to disclose early on just so I have that protection. And it just helps me like self-advocate in general and be more vulnerable to others, which I know is not always someone's forte, but just to legally protect yourself, I think is important in the workplace.
No, thank you. That's so important, like the protection part of it. Thank you. Dr. Brennan, so how can families, parents help their children understand, right, their OCD diagnosis? Oftentimes, maybe the doctors are speaking to the parents and the guardians. So what can parents do to support their children in this case?
I think the first step is kind of recognizing and checking any of the parents' own shame or anxiety about their child's symptoms. When you can do that, when you can recognize, ooh, I'm behaving a certain way because of my child's behavior, and then educating yourself so that you can feel more comfortable, that is immediately going to help your kid feel more comfortable and more accepting of what they're experiencing. And then, yeah, reading, kind of seeking support, going to awesome professional groups like the TAA and the IOCDF, right, for more information, educating yourself so that you feel more confident and comfortable, and then finding the right words to help your kiddo understand that is the way to go, hands down. That's a big piece for age, right? They might need different words at different ages, but a parent is going to know those words for their kid better than any professional. They're going to be the perfect translation tool.
Translation, parents as translators. I love that. Ez, let me ask you, so how can education professionals empower, right, individuals with TS and OCD to self-advocate at school?
I think one way that I'd definitely like to see more of, that I think we have very easy access to, is just having students more involved in accommodation plan development and intervention or counseling development for them, especially if they're an older student. But honestly, I'd say even starting in like 3rd or 4th grade, these students are a lot more capable of hearing these things than we give them credit for. I've had students that I've worked with that didn't even know they had a diagnosis. And then I've had students who know, but don't know that they're receiving accommodations. And I know that a lot of these students benefit from sort of knowing what the options are. I mean, people with OCD, we want to know, we just want to know. And the fear of the unknown is a very strong prevalent stressor. And so I think that's partially why it's important to involve them. But even more importantly, we're giving them agency, we're empowering them, and we're kind of reminding ourselves that this isn't something that they should be ashamed of. And this is something that we can teach them, is just one part of them. And also that this is something they have the power to assist in the change and to make the situation better. We're not going to do it for them, we're doing it with them. And I think that kind of recognition is invaluable. The other way that I would say is a good way to empower is literally just being a good listener without judgment, and just making sure that they know that you're there for them, even if it's not explicitly saying I'm there for you, but just being able to say, someone, they know that they have someone looking out for them in the school. I think makes it more likely that they'll feel comfortable talking to you about more and more things, and then listening without a judging ear. I think educating ourselves on OCD is important because there's a lot of themes that kids maybe are afraid to talk about, but then when they talk about it, we want to respond appropriately. And I think it can be easy to exaggerate or be scared yourself of a student's coming to you with like a harm obsession or something. But it's really important that they know that we're here to listen and we're here to accept them regardless of the theme. And I think that in and of itself is very empowering.
Thank you. Thanks, Ez. And then I think just the last roundtable question to kind of finish up with Dr. Bennett. So I know you mentioned this, previously. Any self-advocacy tip strategies for a parent, right, seeking that OCD diagnosis for their child? Any other tips that you can share with the parents on this call, maybe?
Sure. It's so important when you have a concern about your child's health and well-being to consult your pediatrician or talk to a teacher or a counselor or someone within the school system to gather more information, and as well as to seek resources and referrals. With both OCD and Tourette, I think it is important, and we were talking about this right before this event started, this challenge that exists. And it's so important to find a doctor who has knowledge about OCD and Tourette, because there is a lot of misdiagnosis or misunderstanding with each of these conditions. So you want to know that the person you're talking about has reliable research supported information and treatments. And also, these people can be hard to find and there can be long wait lists. And that's where wonderful agencies like the Tourette Association of America and the International OCD Foundation, making sure you're getting information and referrals from these trusted sources. There's a lot of misinformation, that people can happen upon. So we stick to trusted sources. You talk to your doctor and use the resources available to you while you're waiting for an expert diagnosis and treatment plan.
Awesome. Thank you so much, Dr. Bennett. And I think that's going to wrap up our roundtable portion of tonight. I know I went a little bit over time, but I think there's a lot to be said about on this topic. So I appreciate all of you for sharing your insight. Alexandra's going to be quickly screen sharing actually a QR code and also sharing into the chat a link to that survey that I talked about earlier today. So if you enjoyed tonight's conversation, please let us know. Go ahead and scan that QR code using your phone, and we'd love to hear from you. We really do take your feedback to heart. And, we want to prove to the CDC that this is valuable. This is essential programming for our families and communities. So please let us know your thoughts in there. All right, so I'm going to go ahead and start a kind of our live Q&A session. We have about maybe 7-8 minutes before the end of the hour. Looks like I think most of them were answered, actually. Thank you so much to our panelists. Some of you were typing away as I look here at the Q&A. I actually had a few questions from registration that people submitted. So are you all okay with kind of maybe going through some of those? I picked out some that were maybe, thematic in nature. Like I saw kind of these questions come up again and again. And actually the first one, I think maybe for Sam or Ivette, what would you tell your younger self about living with and treating OCD? So your younger self. Anybody want to chime in?
Sure. I think for me, one of the things that's the most helpful for me is when I started exposure response prevention therapy. But it's just learning how to kind of sit in the uncomfortable feelings. And although it absolutely sucks sometimes, it was so beneficial. But just for example, like I mentioned, how one of the obsessions I had was, how my body looked, and just being willing to sit with a thought of, okay, you know what, maybe I'm a little bit fatter than I want to be, or I don't have enough or as much muscle as I want. And just learning how to sit in that thought process. And instead of trying to avoid it or do a lot of really unhealthy things to try to, fixate on that obsession, just really learn how to deal with the emotion in a healthier way. And that would have just over time caused a lot less stress that I dealt with.
Nice. You have anything to add to that, Yvette? What would you tell your younger self?
Yeah, definitely. I don't know if this is like a relatable experience, but I come from a minority community. So my family's Cuban American immigrant family. And I actually didn't get therapy until I was like in college. So I definitely think it's a privilege to be able to have that option. And I would want to tell my younger self that it does get better. Um, and that there are options and resources and support. and to just keep having that hope and like be very lucky that I'm still here today, because there were points that I didn't have hope that the future would be so great. And sometimes it's still tough, but there always is something to be grateful for. And there's always something that can change in your life, ups and downs that can get better.
Thanks, Yvette. The access to resources is very important to highlight there. Maybe let's see, let's go to Dr. Brennan for this one. So if someone put into the registration, how do you deal with family members who don't understand someone's diagnosis of TS and or OCD? So maybe not the parents, perhaps maybe a relative within the family. Answer that one.
Yeah, I mean, maybe this is a little bit of a broken record, but I always come back to education. If you can provide what at least appear, if you can provide resources to those individuals to say, hey, this is real, this is a legit thing, it's not my kid misbehaving, I think that's a great place to start. That being said, sometimes those folks won't accept that those educational materials and might not be as open to just the information in general. And I think, unfortunately, in those cases, it's really about protecting your kid, advocating for your kid, and setting appropriate boundaries if someone is refusing to get on board.
Thank you for that. Let's see here. And we have a question from Stacy Gooding from our audience. How do you support a college kid that just wants to be normal and trying to learn to do life on their own without parental intervention? So maybe Dr. Bennett, want to try and take this one?
Sure, it's so tricky. As parents, one of the toughest trials can be learning when to support and when to scaffold, or kind of allow your kids to try things on their own. And sometimes it doesn't always go well, but to also understand that one of the most important experiences that young people can have is to fail and make a mistake and learn from those mistakes. And that often parents who are constantly accommodating symptoms or intervening or taking over when anxiety is making something hard, that's actually taking away opportunities for young people to build the skills that they will then need later in life. So it's kind of a tightrope that we have to walk, because obviously we want to support our family members, our children, our friends, and also to understand that when we struggle, we have opportunities to learn and to build those skills that are so essential. So hopefully we're doing that throughout development, from childhood to adolescence to young adulthood. And in college, connecting your young adult child with the resources that may be available to them on campus. So you as a parent may step back and feel more comfortable knowing I've connected my child with a therapist or a resource center or a support group or other people who can help them to understand their experience and to scaffold. So there's these sort of in-between steps that we can take as we're learning to become more independent and to gain those skills that we need to be successful and meet our goals.
Oh, such a good tip, Dr. Bennett, leaning on the campus and the resources that they have there. So I think I don't see any other question. Oh, we have one more question. I think one more question for tonight for Yvette, actually. Remind me what work setting you work in, and since you disclosed to your leaders, coworkers, how do they respond about knowing you have TS and OCD? Do you get positive responses? So we'll finish off with that question.
So I'm a speech language pathologist, and my most current setting was the school system. And I have gotten a majority of positive responses and definitely some questionable ones. So in my last job, I had kind of an issue getting reasonable accommodations when I did disclose earlier and later needed them. And, unfortunately, you may face that, but I've also had people who are very accommodating. And one of my externship supervisors was great. Like, she would tell me if I need a sensory break, like I can have that. If I'm having a really tough day, like I can get a day off and like make it up another time, or like don't worry about it, very understanding. And I think a really important point is that, at least for me, knowing when you disclose, expect either answer. Don't go in like you can go in hopeful, but be ready if they don't have like a very, accommodating answer, and just, I would say, stick your ground and do the best that you can, to either thrive in that environment or know that you need a different environment. Because I did that in the past when I've had disrespectful supervisors. So just take care of yourself and know that you are good as a person. Other people just don't fit well with you. It's not that you don't feel well with them.
Oh, wise words, Ivette. Thanks so much for closing out tonight's live Q&A portion. And I just want to again thank you to all of our panelists tonight. You're all amazing. I learned so much, and I hope the audience found it informative as well. So as a reminder, there's a link in this to the survey also in the chat, so you can go there as well, and please complete that. We'd love to hear from you. For attendees for tonight, you'll also receive a follow-up email within a few business days with the recording of tonight's event, and it'll also be on our YouTube page for TAA, so keep an eye out for that. So on behalf of the TAA and IOCDF, actually guests here, I thank you so much for joining us tonight, and I wish you all a good evening. I'm going to go ahead and stop the recording. Thanks so much, everyone. Thank you.